You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're going to look at a Paediatric Critical Care Compilation, which brings together three of the most important conversations, really, that we've released on the podcast. Caring for critically unwell or injured children in the pre-hospital environment is rare, but it's also high stakes and cognitively demanding. And it really is prudent to get it right. There's often more than one patient, so there's often the paediatric patient, but also the parents. And it makes it extremely demanding for multiple reasons, really. So in part one, we speak with Anna Dobbie. Anna is the previous clinical lead for London's Air Ambulance. She's a former work colleague of mine. We look at paediatric assessment in critical care with Anna and just the fundamentals of paediatric assessment in critical care, from structured approaches to airway, breathing, circulation, but also neurological evaluation and things that actually you can reproduce when the stress and pressure is there. From recognising the subtle red flags that signal serious injury to building really a framework for managing these kind of paediatrics of all ages really under pressure. So part two expands on this into really conditions that we're most likely to encounter in the field. So we're joined by Sarah Edwards, who is the educational lead for the Royal College of Emergency Medicine. And we explore in the episode respiratory infections, asthma, seizure, gastroenteritis, dehydration, febrile illness and trauma. So it's a wide-ranging conversation, and we look at the emphasis really on pattern recognition, early prioritisation and avoiding common pitfalls. We also examine critical role of caregivers and the communication skills required to manage fear, uncertainty and complexity in real time. So finally, in this compilation, we speak about paediatric cardiac arrest with Paul Banerjee. Paul is the medical director for one of the largest EMS providers in the US. And he really walks us through how he's changed a system to achieve dramatically improved survival rates from paediatric cardiac arrest, from protocol innovation and willingness to change convention. And it's a fantastic episode, really, with pearls of wisdom from his insights as to what works. So across all three episodes, the central principle remains really that these discussions are designed to inform and provoke thought, but please do be mindful of staying within your local guidelines, governance frameworks and indeed protocols. So this compilation really is essential listening. It's content which has potential to directly influence how we care for our sickest patients, but I can very much attest to the fact they are some of the most stressful clinical situations I've been in my career. And I hope that these pearls of wisdom really do confer some reassuring principles about doing the basics well and getting back to fundamentally what matters. Okay, please do enjoy.
You see these little charts that sort of say the average respiratory rate, the average blood pressure and stuff. I have no idea what the normal physiological values are. I just don't remember them. And so I always carry one of those little charts on my lanyard around my neck so that I can refer to them. And I think that's a useful idea because it can often catch you out. You can see a pulse of 140 and you're like, oh gosh, and actually look on your chart and you go, actually, that's physiologically normal. So I would never recommend trying to learn, maybe having an idea of the sort of values of the parameters can go up to, but certainly make sure you've got one of those on and use it. There's absolutely no shame in referring to value cards and PEDS, aid memoirs for drug doses and stuff when you're doing paediatrics. And I think there's strength actually in checking your decision making and your calculations and things with aid memoir cards. So I would strongly advocate those. I think the other thing to think about is the children can pick up on how you're behaving and reacting. And we are all a little bit more on edge when we've got a really sick child in front of us. You know that the other emergency services on scene will also be feeling the same. There may well be parents on scene who are going through the worst day of their lives. And so just being aware of your facial expressions and a degree of calmness. I always say to people, actually, the small paediatric cases who are really sick are the ones to go just that little bit slower. Take a deep breath, slow yourself down, calm yourself down, and actually you can almost go quicker by doing that. Take your time and do it once and do it well.
So looking at red flags, Anna, and just maybe some of the red flags that really stick in your mind for critically unwell paediatrics. How can pre-hospital teams really recognise these early, and what's your counsels when maybe mentoring and or signing off some clinicians at London's Air Ambulance?
Yeah, I think if you approach the scene, again, particularly from my area of trauma, and the child is still lying on the floor, that's a key thing. Just as simple as that, of just the child hasn't got up, isn't in mum's arms, is wanting to lie still. And if you think about all the children that you've seen in your practice, the ones that are really unwell or that have broken necks or broken legs are the ones that can't get up and do anything. The ones that get up, cry and give mum a cuddle generally don't have anything too life-threatening wrong with them. And that can be quite a reassuring sign. But the ones that are lying still or that abnormal cry, we've all heard babies crying and young children crying, but actually when they're really poorly, their cry changes. And if you've heard lots of normal cries, you'll recognise that abnormal cry. And there's just something about it that makes you just go, hang on a second, that's not quite right. And I think we'll talk later about the paediatric GCS, and abnormal cry is in that, and how on earth do you define that? But when you've heard lots of normal crying, there's something about it that you can just tell. It's a bit like when you look at lots of ECGs, you can identify the ones that are abnormal because it's an abnormality based on lots of experience of normal. So I think that's my two things that make me the most worried, is when I see a child lying on the floor still, or when I hear that abnormal cry. And those are my two things that kind of make me go, hang on a second, this is potentially quite serious.
What are some of the key considerations, Anna, when you're assessing and indeed managing a child's airway in the pre-hospital environment, certainly in critical care?
Yeah, we recently have just looked at a whole load of the paediatric cases, and we went to about 800 paediatric cases. So that was below the age of 16 over 5.5 years. And we actually intubated about 10% of those. So a reasonable number. But the reassuring thing was when we did intubate them, the intubations were relatively straightforward. And I think that's the reassuring thing to take away from this, is their airways are normally relatively anatomically normal. They don't normally have all the added complications of obesity or difficult scarring or things that we see in adults. And so the decision to intubate is the key thing here, whether the child needs intubation, rather than the difficulty of the actual procedure. When you make the decision, the procedure is actually relatively straightforward, and we know we have a very low complication rate when we do decide to intubate. However, along with that, you then have all the differences in the drug doses and things like that. And we know that classically children or babies have big occiputs. And so when they lie flat on their back, they'll naturally bend their head forwards and naturally obstruct their airway more. They have things like these large floppy epiglottises we talk about all the time. And there's lots of differences that you can read about and list. But I think the main thing is to really think about, how do each of those differences make a difference when you're doing a procedure or thinking about putting a blade in and trying to get a view of the cords. And I don't think we should make a massive deal over it, but it's worth thinking, I don't think when you're intubating a 2 or 3-year-old pre-hospitally, it's not the time to start grabbing a Miller blade if you're not used to using a Miller blade. Go with what you know, make it familiar, and do the basics well. And I think the other thing to think about in paediatrics is often the airway is very easy to manage with basic manoeuvres. So you can get a good seal with a bag valve mask with 2 people. You can put in an oropharyngeal airway and relieve airway obstruction. It's very easy to do a jaw thrust so basic airway manoeuvres are generally easy on a smaller child compared to, say, an adult or a 90-year-old. So I think that's why we don't always have to intubate based on traditional decision-making in adults. And the main reason we tend to intubate in kids is if the breathing is not adequate, rather than as an airway obstruction, because on the whole, the airway is reasonably easy to manage with basic manoeuvres. And also, if they're smaller and you think they're going to vomit, then again, it's quite easy to turn them over and suction them and drain and sort of stop them from aspirating. So it's a slightly different decision-making process, joined along with all these little anatomical variations that we sort of go through. And just bearing in mind these sort of things. So, everything's a bit smaller. So we need to pay meticulous attention to the tube sizes so that we get the biggest tube we can do, but again, not too big that it causes damage to the delicate structures of the airway. We need to think about the positioning of the patient. So because of their big occiput, put something underneath their shoulders so that you get them into a nice neutral position to intubate. So I think it's not something to get hung up on, but something to be aware and to think about how you might slightly change the way that you're doing what you normally do because it's a smaller child.
So you mentioned breathing, Anna. So let's just double click on breathing and ventilation. Could I get you to speak to how providers and staff assess respiratory rate, effort and effectiveness in children, and maybe some of the common signs or red flags in your mind for respiratory distress or failure?
So let's imagine you go to a 56-year-old with a head injury who's got a GCS of 6. Now, within our service, that would be a fairly easy decision to do a pre-hospital RSI for neuroprotective strategies and to control their end-tidal CO2 for their head injury. Now, in children, the question I always ask when I'm thinking about whether I should be intubating a child or whether I'm called on call about whether we should be intubating a child is the breathing normal? Because we know that children look after themselves pretty well, for a want of a better term. So they control their end-tidal CO2 pretty well for their intracerebral pressure. And it's only when the ventilation becomes impaired that they're then not able to do that. And I think that is the key point where the risk versus benefit, so the risks of intubating a small child in an unfamiliar environment with the inherent risks that entails, because it's not without risk. We don't do many pre-hospital intubations on under 5 years old. I don't think anybody does. And in hospital, you have to be a specialist paediatric anaesthetist to intubate very small children frequently. So it is definitely a risk-benefit scenario. And I think only when that threshold is met, that the ventilation is impaired, they're having apneas or the ventilation isn't adequate, does that risk-benefit ratio then tip into the benefit of actually doing a pre-hospital RSI? So it's a slightly different decision-making process. It is not quite so black and white and straightforward as it would be in an older adult. But the beauty, again, of paediatrics, I keep using that term because they tell you what's going on. So they may well not have rib fractures because their ribs are traditionally much more bendy and their bones are far more bendy. So with the same sort of insult that would fracture ribs in you and I, a child may not get associated rib fractures. However, what they will show you is that if they have respiratory distress, you will be able to see it. Because their chest walls are that much more compliant, we've all probably seen it in bronchiolitic babies or asthmatics. The recession they get, the subcostal recession, the intercostal recession, the tracheal tug is very obvious. And so you can actually see the respiratory distress in front of you, which is slightly different and far less subtle than in an adult. Sometimes in an adult, you don't always pick up these signs straight away. Sometimes you think, well, perhaps they're breathing fast because they're in pain or distress. But in a child, if they're working hard, you can see it. And so actually it's a lot easier. But just remember that these small babies have far less type 1 fibres in their chest wall. And the type 1 fibres are the ones that are fatigue resistant. So they can only go on for so long before they get exhausted. And you can see when you see a baby working hard, it's hard work. They're really going for it. Yes, if you can see that increased work of breathing, high respiratory rate, lots of recession, then you know there is a definite problem somewhere in the chest or in the airway that's causing obstruction. The other thing to think about is with tubes and things, they're all a lot smaller. And we know that any reduction in the radius of the tubes, so for example, the endotracheal tube or in hospital in a chest tube, reduces the flow significantly. So meticulous attention to detail and regular suctioning, making sure that the tube isn't blocked by blood or a clot or mucus in the case of medical patients is really, really important, because any decrease will significantly impede the child.
So let's look at circulation for a minute, and could I get you to speak to really around what are the best practices for assessing circulation and perfusion in children, particularly when obtaining a blood pressure and/or pulse is extremely difficult in this sick cross-section of children?
Yeah, so I think we all remember from our physiology that babies and kids notoriously compensate well until the very last point. So they tend to have good blood pressures, and blood pressures are often normal and reassuring till quite late in blood loss. And they compensate through high sympathetic tone. So that means they increase their heart rate, they vasoconstrict, but actually small babies can't change their stroke volume as you and I usually would. So remember, blood pressure is heart rate times stroke volume. And young babies have a relatively stiff heart with low ventricular compliance when they're small, and so can't have that subsequent increase in stroke volume. So all they can do is vasoconstrict and increase their pulse. So look at that pulse carefully and think about it. And if the pulse is raised and the baby isn't distressed, then there's got to be a reason for that. And it may be that you're missing blood loss. The other thing that I think is really useful is you can try a blood pressure by all means. It may or may not give you some clues. It may or may not read easily, but feel the baby or feel the child with the back of your hand. What's their temperature? Yes, if they've been exposed for a long while, they might be chilly around the edges, but what are they like centrally? And then the most important thing that I find that I use all the time in my paediatric practice is capillary refill time. And I think that is possibly the most incredible extra tool that you have available to you in peds, because it just tells you so much. And that is, just to refresh ourselves, press centrally, so over the sternum for 5 seconds, so 100, 200, 300, 400, 500. And the pinkness should normally return within 2 to 3 seconds. What's more useful rather than an actual value, because again, it's a slight estimate because you're doing it in your head and not on a stop clock, is an abnormal range. So if it's over 3 seconds, you know you've got a definite problem. And actually, I use the capillary refill time to guide my transfusion practice. And so when I'm transfusing a small child, I repeatedly do the capillary refill time just to guide myself so I can get an idea of where I am in terms of volume repletion. I think the other thing to think about in circulation is access for these children and how you're going to establish that. And again, that can be trickier, particularly in a volume deplete child. I think in the smaller children, don't underestimate the power of a well-placed IO. I think we used to think that was sort of a poor man's IV access, but actually you can, with a well-sited IO, you can give large volume blood resuscitation through it effectively with a good setup of a fluid warmer, a 50 ml or a 20 ml syringe, depending on the size of the child. And you can give a balanced transfusion with a plasma and a blood attached to the other side of the fluid warmer. And we found that we can actually get good volumes into these children. The other thing to think about is most pre-hospital providers don't have specific large bore access made specifically for children. And in fact, quite a lot of hospitals don't have that sort of equipment down in ED. And you can kind of make the most of what you have. And I say that again, when you're wanting to get big access in a really sick 2-year-old, it's not the time to try out central venous access in a place that you're not familiar with. So go with what you're familiar with and use things that you usually use. So in a small baby, something like a green Vigon arterial line can be useful to put in as a venous access, and just be careful with the length that you're putting in. When we get a bit bigger, we now advocate using our 4 French catheters that we use for Reboa, again, either in a femoral or a subclavian access, and just watching the line. So you can use things that you have in your kit and put them in places that you're familiar with doing. So to be able to establish appropriate large bore vascular access in these exsanguinating smaller patients. The other thing that I think is really key is when you're doing your assessment of the airway, breathing and circulation, as we've just talked about, is your meticulous attention to detail when you're examining the patient, so that you do find any findings that are actually there. I think sometimes, I certainly do it myself occasionally, as you have learned these examinations and they're so ingrained in your practice that you're examining a patient and you're doing your thing and you finish the examination, you're like, I don't actually know what I found because I wasn't concentrating 100% when I was feeling the rib round here, or listening totally to the heart sounds when I was listening. So I think you can come away from an examination sometimes without much information. And I think the thing you have to do in children is examine with intention. You need to imagine that your hands are the CT scanner and that you're trying to find every single injury, because we know that in kids, because they have less body fat, their ribs are more compliant, their internal organs in their abdomens are not as well protected by the rib cage, so they're more exposed and they're more prone to injury. We know that injuries that you find are generally significant. So this is not written down in a medical textbook, but pretty much every time that you see a large abrasion on the abdomen over the spleen, then when you CT the child, there's a splenic injury. So I always say that actually things you can see on the surface are really significant and generally represent something that's injured below as well, because of the physiology and body habitus of these children. The last thing you need to be doing is trying to apply a non-familiar complex scale of paediatric GCS. I think I'd go as far as to say I absolutely hate it, and I don't think I've ever used it properly, and it's just it's not what you need in that moment, and so I'm very much on the side of the AVPU scale. It's familiar, it's easy to do, we've all done it multiple times, it's quick. The thing I would say is, within the paediatric GCS, the useful thing to do is to write down or to just note, what is the baby or child actually doing? So is there that abnormal cry? Are they doing abnormal posturing? What does that abnormal posturing look like? And then we can put that together at a later stage, because actually all these things are really quite useful for the neurosurgeons when you get to hospital to help guide management and decision making. So it's not to say that these GCSs aren't important, it's very difficult to do in the heat of the moment. So try not to get too hung up on exact numbers of the GCS, but the descriptions are far more useful. And the other thing is the worry that actually you interpret what you're describing as the wrong number, and then that gives the wrong message anyway. So I would not use a formal number on the GCS. I would stick with AVPU with descriptions of what the child or baby is doing. Yes, I mean, I think it's obviously horrific for any parent to see their child injured or significantly unwell. And you almost have a second patient when you've got a parent or parents on scene, or a close family member. They are your fiercest critic. You know, you are treating the most precious thing in the world, and they are anxious and scared. And my line is generally to try and keep them with the child if at all possible. I think that hand-holding is key. If they are creating difficulties with you being able to give the treatment that you're wanting to give because they are so upset, then I think there is a time and a place to say, I'm going to get you to stand over here so I can concentrate on giving really good care to your daughter or son. But I think if you can, or at least for some part of the time you're with the patient, to get mum or dad in to see them, to hold their hand, give them a kiss, things like that, I think really make a difference. The conversation I tend to have with parents is I go and speak to them. I introduce myself and I explain what's happening. I say, I know this is the worst thing that you can ever possibly imagine. The way that we're going to get through this is just to think about it in 10-minute slots. We're not thinking about tomorrow. We're not thinking about 2 weeks down the line. We're thinking about getting through the next 10 minutes. And in the next 10 minutes, I want you to go into the house and I want you to get any medications. I want you to pack a bag with some things you'll need at the hospital. And then I want you to come back to this police officer and we will look after you. We will then give you what to do in the next 10 minutes. So it becomes a manageable amount of time and a way to actually function in this most horrific scenario that these people have found themselves in. And that 10 minutes at a time, having spoken to people afterwards, people find that quite useful because it's a manageable amount of time to, I'm not thinking about anything else. I'm thinking I can get through 10 minutes. We can all get through 10 minutes of whatever that 10 minutes is going to show. and then we can think about the next 10 minutes. And I found that quite useful, not only with parents, but also with relatives of critically injured and unwell patients.
Yeah, so I think what I just wanted to speak to the listeners about is really I want to talk broadly about bronchiolitis, viral induced wheeze, and asthma and what they mean, because I think one of the challenges is with, lots of people is unless you work with children a lot of the time, people's confidence, can be mixed, and that can make people, understandably, even somebody who does this as a career, get a bit anxious about that poorly child that they see in front of them. So bronchiolitis typically is that sort of respiratory illness, snuffly, noisy chest, breathing really fast, usually goes off feeding. And usually that typically is in the patient that is less than 1 year old, can stretch up to 2 years old, but usually, the ones and unders. Next sort of comes the pathology of the viral induced wheeze, which sort of starts in that sort of 1 year all the way up to sort of 3, 4, 5 years. And this is much more predominantly wheezy in nature. So you see that child, they're breathing really fast. They've got that typical wheeziness that you would expect. And very much, that age range as they get a little bit older, sort of 3, 4, 5, sort of moving into that sort of asthma territory, which lots of your listeners will probably be familiar with, see it really commonly. And, very wheezy, breathing fast, all of those sort of typical sort of asthma symptoms that you're getting. And I think the one takeaway thing that I want to emphasize is for bronchiolitis, for those particularly under 1, they can sound wheezy, they can sound crackly, they can sound all of that. They can have a low grade temperature, so 38, even 39 degrees centigrade. They can look really tired, they can be working hard, not feeding. But the key thing is with bronchiolitis, and that I always stress with all my juniors when I have the opportunity to just chat to the pre-hospital staff and the students, is please do not give them salbutamol, please do not give them nebulized saline, please do not give them anything like that. It is symptomatic relief. So oxygen, fantastic. If they're a bit warm and a bit grumpy, great, give an antipyretic such as paracetamol or acetaminophen. But nebulizers don't work. Lots of the other things that you might want to give to make you feel better, that you're giving something to hopefully try and make that child feel better, and the anxiety, please don't in bronchiolitis. When you're sort of moving into that 1 year plus and it's predominantly wheeze that you can use, by all means start thinking about trying a nebulizer, or if you've got them, or if they happen to have had viral induced wheeze or they have their own inhaler, use that blue inhaler, predominantly blue, so Ventolin or salbutamol inhaler, giving 10 puffs through a spacer, and that's really important. And I think for me, I think it's just really understanding, and it's hugely challenging, that bronchiolitis versus that viral induced wheeze asthma patient. And the asthmatics, I'm speaking to an experienced audience here, I'm sure, but asthma is hugely life-threatening, and we really need to get that treatment in as early as possible with those inhalers or nebulizers, whatever we've got access to.
Could I get you to speak to, in your mind, Sarah, some of the key signs of dehydration in children, and indeed how pre-hospital teams can best manage fluid loss in paediatric patients?
I think, firstly, recognizing that a vomiting child or one that's got vomiting and diarrhea is hugely stressful. And it's not to say none of what we're talking about today is hugely stressful, but I think there's something about food and not eating and not drinking that really stresses everyone out. And, I think recognizing that, and I'm sure everyone does. For me, really important things to think about are try and get a blood sugar. That's really, really important. No matter what age, that really can help you. I've been caught out so many times in my career thinking that it's just a bit of gastroenteritis, and it turns out to be a diabetic ketoacidosis, or turns out that they've got really low blood sugar. And thinking about, looking at that child, observations, A to E assessment, those basic things. But, how are they? What are they behaving like? What is it the parents are worried about, or the caregivers? have they weed? When was the last time they weed? And I think one of the things that's really important is that it's difficult when you've got diarrhea, because it's likely that children are weeing, but you just can't see it because it's all mixed up there. Truly dehydrated children, I think, are quite often easier to spot than those ones that you don't know where they're sitting. They're quite sunken eyes. They just look really withdrawn and really quiet. They've not really weed at all in the last 12, 24 hours. They might be very lethargic. They might have a low blood sugar. So those are some of the things that I'd be thinking about. So I think I'm going to pivot it the other way, which is, so sepsis and meningitis, fortunately, in most of the world, is very rare in children. In places where vaccination perhaps isn't as robust as it could be, obviously you've got to be thinking about that more broadly. So, but generally sepsis and meningitis, thankfully, in most children is rare. So I think I'd start with that. It's the thing that lots of clinicians worry about. It's hospital or pre-hospital clinicians. They don't want to miss a meningitis. They don't want to miss a sepsis. And I think it's recognizing the other side of that is that febrile illness is hugely, a regular thing that we see with children. And I guess a bit like with the dehydration and gastroenteritis is really understanding what age is that child. So if this child is less than 3 months and they have felt warm or they've had a fever, that is sepsis until proven otherwise. So NICE guidelines, so the National Institute of Clinical Excellence in the United Kingdom, and lots of other national guidelines around the world is, fever under 3 months old is an emergency until proven otherwise, is sepsis. So no ifs, ands or buts, no getting the parents to drive them to the emergency department. They've just got to come. As they start to get over that 3-month age, the fever and that febrile illness, just need to really, take that history, find out what's going on. And lots of the things that we've already talked about. How is the child? What are they like? How long is it going? The really septic children and the really meningitic children are hopefully obvious. They're lethargic. Their observations are all over the place. They're not weeing or haven't weed at all. They look grey. They look ill. And for all of the listeners out there, I'd highly recommend a free resource called Spotting the Sick Child, developed over 20 years ago using real life videos of sick children. It's a free online course. You can get a certificate for it and you can work your way through it. Highly recommend it. And I think the other thing that I worry about is how long have they had the fever? So kids can have fevers for a couple of days. Yeah, that's fine. And they'll be grumpy, they'll be fed up. But as long as they're as long as they're drinking, as long as they're weeing, they're generally looking all right. You give them antipyretics, or you might give them something like ibuprofen, just to help with the symptomatic relief. And generally they're okay with it. If they're sort of getting to day 4 and 5 and they've still got their temperature and something's not quite right, I want to see those children in the emergency department. There's some really rare conditions called Kawasaki's, which is where you get persistent fever for over 5 days. It's a vasculitis, and that is an emergency. Meningitis, I'm sure our listeners are familiar with, with rashes, irritability, just not quite right, high fever and all of that. So I won't dwell on that too much, but those are some of the things that I'd be thinking about with, those febrile illnesses that we see. So I think you alluded it into the introduction to this little bit about seizures. So for me, is it febrile or is it afebrile? Because those two pathologies are very different. And then the other thing with that is I always think about the age. So and whether they're febrile or afebrile. So typically, if we talk about febrile seizures, for me, so usually sort of 5-6-year-old children, sort of the maximum that I'd be expecting that they will get febrile seizures. It could be any age up until that point. And then, non-febrile seizures, so if they haven't got a fever, can be any age. So, and both essentially, you manage the same way. You do an A to E assessment. You make sure the patient is safe. And, if they are continually fitting, whether they're febrile or non-febrile, and they're getting to that, 4 or 5 minutes, you need to start thinking about, well, what medication do I need to give? And usually it'll be a benzodiazepine. So that might be Bucolam, so midazolam. It might be rectal diazepam. In some services, they can use intravenous diazepam. Whatever is on your prescribing, you need to give it. And ultimately, to me, as a hospital provider, if they are still fitting at sort of 3, 4, 5 minutes and you're struggling, you start down that medication route to manage that. And again, while always managing that A to E, and thinking about those little things that again have caught me and every now and again still catch me out, and I should know better. Checking a glucose, don't ever forget your glucose. Checking that the story makes sense. So I've had, unfortunately, some really sad safeguarding cases where actually it's been trauma related, especially with little ones. And actually it's discovered that they've got, intracranial issues from trauma. And also thinking about, is what's is this a known child, and is this normal within their seizure patterns? And I think, we'll come on to touch upon this when we talk about parents and caregivers. Actually, if this is a child that is known to fit and they've got whatever type of seizure history they may have, or they've got a complex background, really rely on the parents and what they would typically expect to see with that child, what their strategy or plan is from the hospital. And if it's not working, just believe them and, get them to help as soon as you can.
Could I get you to speak to your experience really of managing paediatric trauma and some of the priorities in your mind, Sarah?
Again, age is such an important thing, but I think it's about mobility of the child. So is this a child that is walking? Or is this a child that shouldn't be walking? And actually, what's the story that goes with it? And I hate to always, think about safeguarding, but it's hugely important. And sadly, safeguarding and non-accidental injury in children is prevalent. And actually, as pre-hospital providers, you are often the first people into that family's home, and that can really get an interesting insight that I will never get because I'm in a clean hospital building. So, what is common? So I see lots of little ones who were in their car seat or, being carried up and down stairs by parents, and they've fallen and they've dropped them. That is really, really common. And again, the most common injuries I often see with those, particularly with little ones, particularly with babies, because they've got soft, squidgy skulls, as I like to say, is that unfortunately they often either break their skull and they sometimes end up with a small bleed. So often they won't mark, and often they won't have much of a bruise on their head. And because their skull plates are open, they can get away with a bit of bleeding without them really without them you really noticing, because they've got the space, fortunately. So for those little ones that are non-mobile, really honing in the history, getting that sixth sense that you're at home going, nah, something doesn't feel right. Oh yeah, no, absolutely, I can see what's happened. And most parents I meet who have done, dropped their car out the kid car seat, so easily done when you're tired, or you're walking up and down the stairs in a hurry and you slip and you fall. It's so common, and the story makes sense. And most parents I meet are absolutely mortified. And then talking about those sort of non-mobile children is thinking about, does the story make sense? So whatever the story is, that's important. And as you get older, the story is always important, no matter what age of child you're seeing, but particularly with trauma, is what the child's saying, is what the parent's saying, or whoever was with them, does it make sense? And fortunately, for lots of places in the world, big sick trauma in children is thankfully really, really rare, due to the advent of seatbelts and general safety features, but you do still see it. And whether they are, 6 weeks old, 6 months old, 6 years old, or 16 years old, the principles of trauma management apply. So it's A to E, assessment, so airway, breathing, circulation, disability, and your environment. Don't forget your glucose. But also, particularly with the bigger kids, actually, even in big traumas, I would try and get the parents and the children to work together to keep them as safe and as wriggle-free as possible. And even if it's the worst accident in the world, and you've got a screaming child and they want to be held by their parents, sometimes that is better than pinning them down to a scary bed in the back of an ambulance, trying to board them and put collars around them and all of that. So work with the parents. So my bottom line really is, with trauma in pediatrics, is what is the age? Are they mobile or non-mobile? Does the story make sense? And irrespective of whether they're 6 weeks, 6 months, 6 years, or 16, do your standard A to E assessment, trying to immobilize them where possible, but be a bit flexible in what you're trying to do so that you can give some comfort. And that might involve them being sat in the parent's lap. For lots of years, actually, asthma we didn't see at all. And, actually now it's sort of come back. I'm not saying that the pandemic has caused the asthma or anything like that. What I'm suggesting is that it's just changed how the disease is presented. So the asthma, is unpredictable and can be at any times of year. Thinking about asthma, the sick asthmas, they look tired, they're breathing really fast, you're giving them nebulizers and they look absolutely shattered. Like, they look as though they just want to fall asleep. And sometimes they look grey. They just look, as though they're going to fall off their perch. Conversely, sort of the other end, so those, viral induced wheezes, those asthmas, I think what we really underestimate is the utility of a good spacer and a good salbutamol inhaler at the end of the spacer. So nebulized salbutamol is brilliant, but it has its disadvantages. It's noisy. Kids often don't like it. Most of what you give goes out into the ether, versus that with a spacer and an inhaler where you can give 10 puffs to somebody who is less sick, that can actually get you out of a lot of trouble quite quickly. It is a bit more challenging because, people do wriggle. But actually the delivery of the medication that you're giving with that salbutamol is much more reliable. And particularly if they're breathing really fast, that can be really helpful. And in a lot of guidelines, particularly in the UK, actually for asthma exacerbations in children, provided they're not on the life-threatening end that I've briefly discussed about, using inhalers with spacers is a much preferred option due to the reliable nature of giving the medicine. So that could be easily done in the community, on the back of the ambulance, in participants' homes. And what that may enable you is that you give those 10 puffs. So 1 puff every 30 seconds to a minute, make sure that they're breathing it in over 10 minutes. It takes a while, but actually that might get you out of trouble. It also might allow you to go, well, actually the child's not too bad. They might be able to make their own way to the hospital and then free up that resource.
So I think first thing is you work somebody on scene where they are. And a lot of it is, you have the pit crew approach, which they do in adults. One person's in charge of the airway, one person's in charge of compressions, one person's in charge of the medications, one person's controlling the time. With the fire department, you have multiple system response, which if you look at the pediatric arrest algorithm, it was an alpha response, which means you send the least amount of resources. With an echo response, you're sending the whole cavalry. Everyone's coming. So let's send everybody because we need people. A lot of it is controlling the scene. So you have parents who are distraught, who are unable to comprehend what's going on. Their little baby's dying. Well, how do I get someone to kind of educate? This is what we're doing. This is why we're doing it. We're not moving them to the ambulance. We're not taking them to the hospital. Because if you really know, hospitals do a terrible job when it comes to pediatric arrest. If we don't have a pulse back by the time they get to the hospital, it's a 99% chance that child will die. So the best chance you have is you have basically 10 to 12 minutes before you get ischemic brain death for a child. If you wait for therapy and resuscitation to get to the hospital, guess what will happen? The child will die. Or they'll be brain dead and they'll be good organ donors, which will help somebody else, but isn't too helpful for the family to see their child in front of them. So organizing the scene, changing dispatch matrix. We had the system that we used that is a number-based system. It's called the hand-heavy system. Based on the age, there is a weight given to that child. That weight is basically an ideal body weight, similar, and the medications are calculated based on ideal body weight. It's not exact, it's approximation. But if you look at the tape, there are kind of a lot of variance into what the approximation is. So what we did was we got these are the numbers if you're, and a simple thing is the hand heavy is 5, right? So you have thumb, which is 1, 3, 5, 7, 9 years old. They're 10 kilograms, 15 kilograms, 20 kilograms, 30 kilograms, 35 kilograms. If you know the age of the child, say the child is 3. So you have 3, that's 15 kilograms. I've already the doses that I need, the quantity that I need. So when they call dispatch, they said it's a 3-year-old drowning. And just as a side note, we are the #1 drowning pediatric death area in the world, probably, because we're right near Disney, and a lot of families come over, don't have pools, don't know pool etiquette, don't know pool safety, and that's why a lot of these kids drown. So if we know what age they are, it's a 3-year-old who's drowning or doing resuscitation, the medications can all be drawn up by the paramedics. By the time they get there, everyone already has an assigned role. The one person is immediately going to get the airway. You can do compressions, get the airway. The meds are pushed. There's no thought required. The same as you would with an adult. And so that was the beauty of the simplification of working them on scene, getting the airway early. We also had a PEA bundle, and the survivability of PEA is less than 5%. So the bundle of care was, we have Narcan, we have your epinephrine, we have the bicarb, we have calcium, we have fluids. So basically, of the H's and T's, which they're 12, it hits 9 of them. So instead of trying to be scientific, we just kind of like shotgun approach that rhythm. How do I treat it? VFib, VTAC, we doubled the initial doses. So instead of 2 milligrams per kilogram, we do 4. We would do 8 the next one, and if we have to, double sequential. So it's basically a more aggressive approach. Now, thankfully, we've got a lot of kids back. So once they got them back, so we've given all these medications that they are great because they stimulate the heart. The problem with the side effect is they cause vasoconstriction. So as your brain is getting the brain is already ischemic because it's been down without oxygen for a while. Now it's even more constricted because the medications you've given. But one thing we do better than the hospitals is manage and regulate end-tidal CO2. And end-tidal CO2 is a sign of resuscitation. It's how well the cell's doing. It's a sign of metabolism of the cell, how alive you are. It's a waste product measuring. That means we're living. If we can control the amount of end-tidal CO2 that's released by the cell, we can regulate the peripheral nervous system, the peripheral vascular system. So it also causes renal artery vasoconstriction. It causes heart rate stimulation. It also causes cerebral artery vasodilation if you control the CO2 levels. So what we did was we had it, normally people do between 35 and 45 for end-tidal CO2, but that's for normal people in normal systems. This person's ischemic with a medication that's going to cause vasoconstriction. So let me overcompensate for that, raise the CO2 higher, which will cause the arterioles to dilate more. So we had the end-tidal CO2 between 45 and 55. Obviously, we're working them on scene. We also have an end goal of blood pressure based on age. So based on what age you are, you want to make sure that the brain is being perfused. So that involves saline and involves push-dose pressors to get that map where it needs to be so the brain is being perfused. So basically, it was a whole bundle of care. It's not one thing that we did, and we found amazing results but just by doing that. Yeah, I think the pit crew concept works because we now have an assignment. These are very chaotic, emotionally charged situations. Nobody wants to see a young child die. But if you know your only job my job is to get the airway and I ventilate. Now, the ventilatory rate is another thing we adjusted as well, because normally AHA had 1 in 6 breaths a minute. We've done it to 1 in 10 breaths a minute. The reason we did the end-tidal CO2 to be higher is it mentally slows down the paramedic Because what happens is once you've intubated that child, you want to your adrenaline flows and you just bag. Well, what you're doing is blowing off all the CO2. CO2 is a marker of survival. You're lowering the chance of survival. So by slowing the breath down, taking 2 deep breaths, expanding the alveoli, increasing perfusion, decreasing introthoracic pressure, by doing those things itself, you're going to increase coronary artery perfusion pressures. By hyperventilating, and this is all airway control, right? By hyperventilating, you're going to increase thoracic pressure, intrathoracic pressure, decrease coronary filling pressures, and the person's not going to probably make it. With this controlled approach of the airway, and then they have to be aware of the end tidal CO2, aware of the airway. Initially, when you do the intubation, you want to do, first of all, is 3 minutes of airway management, which means that we do DAI, not RSI. RSI is rapid sequence intubation, which you're doing paralytics, you're doing an induction agent, and you're going to do a sedative. What we do is we do an induction agent and a sedative. So instead of succinylcholine added, they're probably unresponsive and not breathing. They don't really need a paralytic. So we would give ketamine based on blood pressure or etomidate if it's not trauma related. So you have a mental triage of which one you want to use based on blood pressure and mechanism of injury. And obviously Versed, any kind of benzo that you have available to help sedate that patient. But once you have that, we want to make sure that you bag them at 93% for 3 minutes. The reason is the 3-minute time is important because you denitrogenate the oxygen in the system. So if you will struggle with an intubation, and this is more so for adults than children, but if you do struggle with an intubation, you have a little more time to see if they're drowning, they have copious vomiting or pool fluid in their lungs or in their throat that you have to suction and clean to prevent them desaturating. So you're giving them 100% high flow oxygen, kind of like we did with COVID. Once we get that 93% for 3 minutes, then we attempt intubation. You get 1 shot of intubation or a supraglottic airway. And most people in this kind of crisis want to guarantee the airway, so they go to supraglottic airway. And once that is done, that's his job. He's got the supraglottic airway. His job is to bag once every 10 seconds after 2 deep breaths, regulate that end tidal CO2 between 45 and 55, and that's his only job, which is actually complicated in itself.
Yeah, absolutely, and to not overcomplicate that, like you said, it's focusing on one task and one task only, which is fantastic. One of the things we realised, actually, certainly within the UK, both from rescuer data and anecdotal experience, but also from maybe initial first aid or aid rendered into pediatrics, was aggressive bag valve mask ventilation. What this would do is hyperventilate and push air into the stomach, which would as the stomach inflated, it would splint the inferior vena cava and actually prevent ROSC, return of circulation. So what we started to see is a lot of return of circulation post. So we would place a nasogastric tube through into and decompress the stomach, get the air out, and there was a lot of return of circulation beyond after the air had been released from the stomach, just because that was really acting as a splint against the inferior vena cava and that return of circulation. Because to your point, I think partly the issue is on scene, there's a lot of endogenous catecholamine, so your homemade adrenaline, your homemade epinephrine, can take over sometimes, and rescuers can quite aggressively bag valve mask pediatrics to the point where they are, to your point, overinflating, and that air is going somewhere. It's going into the stomach rather than into the lungs, and actually that is actually working against return of circulation. Have you seen that in the field within Polk County?
Well, this was again before we did it, and I'm assuming we followed what everybody else did. But in addition to compressing the vena cava, you're raising the diaphragm, which again, you're increasing intrathoracic pressure, which causes you to decrease filling pressures. So you're kind of working against everything you do. And we do have an NG tube that we put down with the eye gel that, again, is to help decompensate, but you can control a lot of that side effect by controlling ventilation rate, controlling entitled CO2. That I think the adrenaline takes over and people think more is better, and it's not. I think a lot of what you do in life is if you believe you can or you can't. When you see that that everybody dies, that when you do, you're like, well, it's not gonna work anyway. So paramedics are very, very thin people to make them 100% believe in something or not. So now I'm at a stage where I'm so proud that the crews are upset if they don't get a ROSC or a survival, if the patient does not go home. That is a whole mental change, seeing that, hey, everything I do works. And it's worked before. It's worked for me like 30% of the time, which is 6 times higher than national average, probably even higher in the world. In the world, it's probably less than that, because in Europe and USA, it's probably much higher than it is in Asia or Africa, right? So you have this kind of expectation that you're not going to die on my watch, and I'm going to do whatever I can to get you. I've done this before. I'm good at this. It's kind of like you are with adults. You're not going to die on my watch. I'm going to get you. And when you do, you're like, well, what could I have done different, right? So then you actually auto-regulate yourself and go, what could I have done different? So just that whole expectation change is a life changer, a game changer for the people.
Yeah, indeed. Could I get you to speak to really so you, if I'm correct in thinking, you assign, when you have the manpower, you assign someone to the family member just to really guide the family member through in non-medical phraseology or words, essentially just what's happening. So you break it down for them, get them to kind of, allow them in to see the resuscitation, but really support them through the whole emotive process. Could I get you to sort of unpack any feedback you've received from that?
I think the family members are obviously their most important thing that's dead. What are these guys doing? Why aren't they rushing to the hospital? That's where they're going to live. Changing that mindset, going, this is what we're doing right now. We have to get the compression target to get his heart moving before we actually can transport him. So we're on scene for 10 minutes or until we get a pulse. So after 10 minutes, we're like, all right, we're going to try and take him to the hospital now. But we've done everything. There's really for trauma, there's a golden hour. For cardiac arrest, there's really a golden 10 minutes. That's not an official rule. That's my rule. You have a 10-minute rule to get someone back from a cardiac arrest. After that, it's possible, unlikely. So telling them this is why we're giving the epinephrine, we're getting the airway to suction out his lungs, we're controlling the scene, we're getting him the optimal care that he's going to receive to give him the best chance to live. And having them see that and see their breathing change, their eyes change, the mentality change, that, okay, we got a pulse, going to load in the hospital, we're going to this hospital. They're very, very different. And they'll sometimes drive with the family because they're probably not in any condition to drive anywhere. So you take them and they drive with them to the hospital, and, not more times than not, but a significant percentage of time, the child comes back. And there's other options now that are also available, like ECMO, which can be, VV ECMO, because it's usually a pulmonary issue, not really an arterial problem. So that VV ECMO is something we're looking at expanding out as well. I think first thing is to simplify everything you do. The more intelligent we try to be, the more complicated we become. And the more complicated we become, the more confused people are. So find a way or find a system that that you can just wake up in the middle of the night. How are you going to respond at 3 a.m? If you can respond at 3 a.m. the same way you do at 3 p.m, your system's right. So choose a system that is simple. That's a system 1 system thinking. Number 2, every rhythm is different. PEA is different than VFib. PEA has 12 different causes. It's unlikely it's an MI or a tension pneumothorax or a pulmonary embolism in a child. Possible, unlikely. But all the other ones, acidosis, hypovolemia, hyperglycemia, all these things that are there, are we addressing them? Is it an overdose? We don't know, right? Is it hyperkalemia? We don't know. So let's not try to be scientific. Throw everything, if it's a PEA bundle, to get that person back, which is actually in adults, our survival rate's 18% for PEA arrest, which is unheard of. So we're doing the same thing with adults. So you've got the PEA and you've got the VFib, right? Initially, start with what's the first thing you do? They'll call 911. Let me change the dispatch matrix. If I've changed the dispatch matrix, I'll need all the information. Just tell me how old they are. Once I know how old they are, I can drop the meds. I'm ready to go on scene. I know to push all the meds I have. There's no thought required. System one thinking. You work them on scene because working in the back of the ambulance while there's moving at 60, 70 miles an hour, while you're trying to do compressions is not going to be very good or effective. If we can do mechanical CPR, even better. But in a controlled environment, out on the scene like you would an adult, and we do the same with adults as we do children, 10 minutes on scene or until we get a pulse. Then after that, we've done the airway. We've done at least 3 to 4 rounds of medications and chest compressions. We have basically controlled the environment, controlled the temperature, which is another issue. So if they're in a pool, they're cold, we made them warm because you're not dead till you're warm and dead. So we've controlled all the factors we can to give the optimal chance of survival. Now we've gotten the airway. What do I do post-ROS? Because I want the brain to be living. So I've done all the things everybody else says, all the things that AHA says to that point. But what it doesn't address is what happens after you get your result, right? And no system, ASHI, AHA, doesn't mention, what do I do post-ROSC? ROSC is like the goal. Well, ROSC really isn't the goal. ROSC is an intermediate goal. The goal is to have them walk out of the hospital alive.
Okay, that's it for this week. Next week, we're going to be looking at fatigue in EMS with Professor Daniel Patterson, as fatigue is a uniting principle in EMS and something every practitioner has to deal with. He is at the forefront of some of the most influential research programs on fatigue in EMS currently, and we'll be examining that with him on Monday. So please do stay tuned for that. Please do rate, review and subscribe to the podcast so we can get the best information and indeed the best guests back to you. And we're always open for feedback to make sure we are getting the best information back to you. Okay, that's it for this week. Thanks for listening and we'll speak to you soon.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.